Hi, it's Dr. Centeno, and thanks for joining us live today. We've got an interesting topic today. I've seen patients through the years who have complained that a forceful rotational manipulation of the head on the neck, and many times that's a chiropractic manipulation. Sometimes it's a manipulation that's given by a physical therapist, has injured them, and in particular, has caused craniocervical instability. So it's an interesting concept. I've heard a lot. I'd have to say that in my experience to date, I've probably seen 24 patients like that. So I know this happens. It's obviously a pretty rare event. And then this weekend, I was looking at some new papers that have been published in the last year or so. One was a biomechanical model that could explain how this happens. And so I thought I'd share it with you today. As usual, I'll give a short presentation, maybe 10 minutes or so, and then open the floor to questions. You can ask questions about what I'm giving a talk on today. You can ask questions about pretty much anything. So really just go ahead and let me know what you think of the topic as well. So again, just to review, we'll be talking today about this phenomenon that a sudden head rotational manipulation has caused craniocervical instability and some new data that may explain how that happens. So let me go ahead and share my screen here, and then we'll get started with all of that. Okay, and okay, so the topic today is, do the biomechanics of C1C2 explain how a patient can get CCI from a head neck manipulation? Again, for those of you just joining us, I've heard through the years of patients telling me that they got craniocervical instability from a forceful head rotation type manipulation. And one of the things that's been interesting about that is that sometimes it's chiropractic manipulation, sometimes it's manipulation done by a physical therapist, but it's happened often enough, probably a couple dozen of my CCI, of my hundreds of CCI patients, relate this as the cause of their CCI. So this weekend, there was a new paper I was reviewing that's come out in the last year that could explain how this happens. So this is that paper, actually not this year. It's one that came up on my my feed. It's actually old, 2012. I apologize for saying it was this year's. Okay, so again, we've seen patients who report that CCI happened due to a forceful rotatory manipulation of their head. It's the kind of manipulation where someone applies a little traction and then turns the head real quickly. So is this possible? And if so, how would this happen biomechanically? And are there things that would explain how this could occur? So in particular, we're not really talking about a NUCA gentle or specific upper cervical manipulation here, meaning that these are often very low force manipulations with NUCA or AO. Consequently, they're pretty gentle. We're really talking about taking the head and forcefully turning it. So ligaments get damaged when they elongate more than about 6 to 8% of their length, which is pretty interesting. It's a pretty low tolerance to damage if you think about that. 6. So if you've got, let's say, a 10 centimeter long ligament, which is going to be about 3 inches long or so, and if that 10 centimeter ligament gets just 60 to 80 millimeters longer, you're going to damage that ligament. And that's not much. To put it in terms that Americans can understand. If it gets more than a 16th inch or so longer, you're going to damage that ligament. Now, what's interesting is just normal C1, C2 rotation of around 40 degrees causes alar ligament elongation of 17 to 27%, well beyond that 6 to 8% elongation. So how can you turn your head without damaging these ligaments? After all, about 40 to 45 degrees of rotation happens at C1, C2 normally. So how can we turn our heads without damaging these ligaments? And this happens because of the biconvex nature of the C1, C2 joint. I've talked about this quite a bit, that unlike other ligaments that tend to be ball and socket, the C1, C2 is like two sockets turned upside down on each other, or two balls turned around on each other, so that it's biconvex. So there isn't one fitting into the other, there's one opposing the other. And so how this works is that as C1 rotates on C2, which is what's being shown in the upper images there, and let's see here. So these upper images up here are showing what happens when C1 rotates on C2. So from other lectures that one of the things that occurs is those alar ligaments tend to rotate around the dens a little bit. And that could be why we're seeing such stretching force on those ligaments. But the other thing that is happening is that, as you'll notice, C1 and C2 in these bottom illustrations, the C1 is actually riding down the C2. And that's going to have the effect of loosening the alar ligament. Now, the alar ligament is shown here as A, and the dens is shown down here as D. So as you can see, if you turn your head right or left, it's that ride down effect of the C1 on C2, which can happen because of that biconvex joint, which loosens that alar ligament. So you basically get laxity in that alar ligament because of that ride down effect. And that's counteracting that extra stretch that's happening because the alar ligaments are rotating around the dens. So, again, in an upright position where we've got force on C1 and C2, as I turn my head, one joint surface is riding down the other, which is loosening the alar ligament, at the same time that the alar ligaments are winding around the dens, increasing the stretch on those ligaments. So what would happen then if we rotated someone's neck forcefully while we are pulling traction? And that's what's shown off to the right here. This is someone who is pulling traction on the head and they're going to forcefully rotate it. The problem here is that this could increase stress on the alar ligaments beyond the maximum limit. And why? Because it doesn't allow for the shortening of the alar ligaments that naturally happens with rotation due to that biconvex C1, C2 joint. Again, the alar ligaments are loosening because one joint surface is riding down the other, and that's loosening the ligament. But if I'm pulling traction on the head, that ride down of C1 on C2 isn't allowed to occur. So I'm maximizing the stress on the ligament just when I'm further maximizing it by turning the head. So even though this is something that's been taught for a long time, I would have to say that the reason why we're probably seeing some patients get injured and not others is probably, at least based on this biomechanical study, based on the fact that some manipulators are pulling more on the head, thus maximizing stress in those alar ligaments before they rotate. If they don't pull on the head and they just allow C1 and C2 to ride down naturally, you're going to de-stress the ligament. So that's why we're probably seeing that. And I would imagine that some of these injuries are happening because there's just too much traction happening on the head. Maybe you've got an inexperienced person. Maybe that person just did it a little differently this time. Maybe the patient had some pain and they were trying to apply some traction at the same time to see if they could relieve that pain. So we'll go to questions now. It's an interesting concept. Again, to summarize, in order to de-stress the alar ligaments, we have to allow for that natural C1 and C2 ride down. And if we don't have that, then we're going to maximally stress the alar ligaments, and that could put them at risk for damage in a rotational manipulation. So let me stop sharing there. Let's get out of this and see if we have questions. Looks like we got a couple. Krishna, which ligaments are involved when there's an atlas tilt? Well, the atlas naturally tilts as you rotate your head. But if there's a fixed atlas tilt, that can happen due to scoliosis below the area. It also could happen due to laxity of the lateral AO ligament or the anterior AO ligament. So those are two ways that an atlas could tilt on the skull. It also could happen because of congenital changes in the atlas. It also could happen because of other factors like capsular ligament injury laterally. That's possible. But literally, probably the most common thing that could cause that would be scoliosis. And then after that, if it's a ligament issue, it could be due to those lateral AO ligaments. It also could be due to a unilateral alar ligament injury. But there would need to be other things that would have to happen simultaneously. So maybe alar and AO ligaments, those sorts of things. John, does taking NSAIDs completely disrupt the healing of injuries? We know it's not good. We know that the research shows that nonsteroidal anti-inflammatory drugs work on suppressing a pathway that's essential for normal healing. We also know that we have research out there that patients taking NSAIDs or steroids are more likely to get chronic pain, and that's probably the mechanism. So taking NSAIDs is contraindicated in trying to heal an injury, even though it's a common thing that doctors do. The more current research is telling us not to let patients take NSAIDs who have acute injuries. But that's regrettably, most physicians have not gotten the memo on that one. Question about diet. Are there any healthy foods that should be perhaps restricted? Oxalate, spinach, high sugar from excessive fruit intake. Can patients do well with vegetarian diet with supplements? Yeah, the biggest concept here is trying to eat a healthy whole foods diet that's low in its glycemic impact. Glycemic impact simply means low in sugar, low in carbs, high in healthy fats, getting rid of unhealthy fats. So that's sort of the biggest 30,000 foot view concept. Ulysses, chiropractor be damaging ligaments in the neck the most. Gotcha. Regenix been advanced by John Gardner. Hi, I got a PRP injection with Regenix here in PA about 3 weeks ago into my bulging 5, 6, 6, 7. I'm assuming you mean discs. I tried lifting weights again, and it made my neck and symptoms worse. How long do you recommend your patients not lift weights or run after injections? Well, normally disc injections themselves take several months to fully heal and calm down. So best thing to do is to obviously lay off the weights, but obviously you'll need to go back to your specific doctor that did that procedure. John, post-PICL side bending of the head, like one would do, DMX be avoided? How easily can one injure the alar ligaments when healing? Not very easily, and generally just doing side bending of the head is not going to injure them. Lizzie, osteopathic do the manipulation in a gentle way compared to chiropractic. Gotcha. Regenic, submitted advance by Janet. So I was curious about this research. A PT mentioned it, was trying to explain how important it is to do the right exercises properly to create what he called scar tissue on cartilage to help with knee OA. He makes it clear that you can't get back cartilage, but build an existing scar layer to strengthen and reduce pain. Was wondering if you could talk about this paper and research to help me understand it better. Don't think I have the link there. So I need to see the actual link. Caleb, can tendonitis of rectus capitis posterior, major, minor, and obliquus capitis inferior, superior attachments cause destabilization of the head on the neck? Possibly use PRP with ultrasound on these. Sure, anytime you've got tendonitis of a tendon, the muscle's not going to work real well. And obviously, if these upper cervical muscles aren't working, you can get muscular instability or destabilization of the upper cervical spine. For those tendons, for the most part, you could use ultrasound, depending on the patient. In some patients, that would be easier to do. In some patients, fluoroscopy would probably be better. What I mean by that, if you've got a thin patient where you can easily image these muscles, a patient without a ton of hair back here, because hair will interfere with that imaging, then can be done pretty safely on ultrasound as long as you are staying clear of going too deep into the vertebral artery area. If you're at all too deep, then you would need to use fluoroscopy with contrast and digital subtraction angiography. Maya, and that's why I never let chiropractor touch my neck. I find it the most dangerous thing, and even the neurosurgeon agrees to this. Or Maya. Again, doesn't really apply to AO and NUCA chiropractic, but certainly when it comes to rotational head and neck adjustments, it's a concern. AT is a common scenario for patients to feel a bit better a few weeks out after PCL, then afterwards feel worse for a period of time during the healing process. Certainly a common scenario for patients to go through a honeymoon period, and that honeymoon period can be up to a few weeks, and that's when the ligaments are tight due to swelling, and then people kind of crash back to what they were at before. So that may feel like, sort of it got worse, because it did from a relative standpoint get worse from feeling better. So that would be pretty normal. Anya, hi, during last live, you said urinary issues, not due to OTC, a occult tethered cord can be helped through regenerative injections. Could you say the name again, please? It sounds something like caudal, CAUDAL, epidural with platelet lysate. So again, a lot of that depends on what's causing the problem, but the most common cause of urinary issues in a patient with low back pain, especially women with low back pain, would be sacral nerve irritation. It happens in a lot of women, especially as they get older, because those structures down there are not as strong, or after childbirth, where those structures are not as strong. So I think what we talked about was that if someone has concomitant back pain and is getting urinary issues, things like urinary dribbling or frequency or urgency, that normally treatment of those sacral nerves with a caudal, CAUDAL epidural, with something like platelet lysate would be done well before you made the assumption that you were treating a occult tethered cord as the cause, and that patient required a detethering. If a person with no OTC, occult tethered cord, struggles with starting urination and frequency, should the back be treated first with regenerative injections? Yes, I think we just kind of discussed that. That makes sense, assuming there's no reason to consider the issue an emergency. Obviously, there are scenarios where people get large herniated discs, tumors, etc. All of a sudden, they can't hold their bladder at all, etc. So we're excluding those sorts of scenarios. Jim, for neck isometrics to target the suboccipital muscles, I've noticed that if I first point my eyes towards the direction of movement before applying pressure, it leads to more activation. So you first point your eyes towards the direction of movement before applying pressure. I think you mean that if you first look at something and then move your head, that it works better for activation. I think that's great. It's been advanced by Sherry. That is definitely what happened to me. I was seeing a chiropractor for my low back and mentioned my neck had been bothering me. Next thing I knew, he did such a violent maneuver on my neck that if I could have punched him, my neck has not been the same since. And my recent DMX showed I do have CCI with type of chiropractic adjustment. This type of chiropractic adjustment should not be allowed. Yeah, I think what that paper suggests is that if you are a chiropractor doing rotational or a physical therapist doing rotational manipulation of the head, you're going to want to avoid any kind of traction on the head. And I suspect that, like anything in medicine or car repair or whatever, it's hard for everyone to get the memo on all the different steps of how to do something properly. So the steps here to do a rotational manipulation properly would be making sure that you're not putting any traction on the neck. Rishi, if a patient wanted to try posterior injections, I don't think I got the full comment there or question, Rishi. AT, for type 1C, is there an additional benefit to get the above the atlas method? Also, what imaging best shows shallow occipital condyle upright MRI? So type 1C instability doesn't have to be a shallow occipital condyle. That's one major cause of it. And then, yes, the above atlas injections are usually the thing that are needed to be done with that type 1C instability. You'll see a lot of people having vertebral artery dissection because of the chiropractor. Pretty uncommon with chiropractic or manipulation of the neck. I would say extremely uncommon, but it can happen. Eric, I had trauma 7 years ago, immediately noticed electrical shock through my spine, scoliosis and weakness, left foot. I can walk, but weakness has persisted. Can this be indicative of spinal cord damage? It's possible, sure. I mean, that's the kind of thing that if there's spinal cord damage suspected, you may want to go and watch the last live where we talked about that whole concept of you can have negative cervical MRI imaging of the spinal cord, and it could be a false negative that things like diffusion tensor imaging may show a problem, where a routine T1 or T2 weighted image of the cervical cord would show nothing. Rishi, as a patient wanted to maximize their... Still don't have a full question there. James, any diagnosis in getting dental work done when you have CCS or CCI? Any dangers getting dental work done? Yeah, biggest thing there, I think, James, is if you have CCI, just making sure that the dentist understands that and that the dentist keeps you fully conscious during that and doesn't knock you out, so that you can tell the dentist if you're in a position that is aggravating your symptoms. So it's not uncommon for us to see CCI patients that get dental work. That dental work kind of flares everything up. So just be careful. John, how can a layman learn to read medical studies to understand them and even detect bad science? Well, John, that's a big topic. That's a big topic that happens because, or it's a big topic, and doctors who learn how to do that take many years to learn how to do it successfully. And it's not even a topic that most physicians understand. Now, if you read hundreds or thousands of studies, you get the hang of it. If you're working with people who understand how to detect junk science, you get the hang of it. But it's probably not something that, I could do, for instance, in a small lecture. There is a guy on YouTube, if you want to learn some of those things and you've got the time. Let me see if I can pull him up here. Vinay is his first name. Vinay Prasad. So this is his channel. He's an epidemiologist in oncology by trade. Let me kind of bring that up. This is Vinay here, and he does a whole bunch of these. He's done all sorts of things on various studies. During COVID, he kind of got into doing that. He does oncology, but if you just watch him and you watch how he takes apart studies, you can learn a lot. I mean, if you watch 10 or 20 of these videos where he's taking apart this study or that study, and obviously try to find studies that are of interest to you, so they're not boring things to watch, you'll get a good sense of how an epidemiologist would break down a study. So that might be a good thing to do, just to learn that and learn a little stuff. But he's great. He's really quite the superstar and is easy to understand, and it's just a pleasure to watch. Anya, can I ask how it's possible to tell if a person has a occult tethered cord or bladder issues with back pain? If OTC often is not visible in MRIs, how to differentiate these two? Yeah, that's the problem. It's not. And that's my biggest concern with the diagnosis of occult tethered cord and the dozens and dozens of patients each month or more, maybe hundreds, that are getting their filum terminale cut. Because at the end of the day, if you've got chronic back pain, and especially if you're female, urinary issues are common. And it seems like the doctors that diagnose occult tethered cord and that operate on it are using the urinary issues as a way to cinch the diagnosis, or one of those things that can cinch the diagnosis, because the rest of the symptoms are shared by lots of other disorders. Another problem is urodynamics. Urodynamics in many of our back pain patients will show that they've got neurogenic bladders because of that sacral nerve irritation. So that's the concern. So the only real way to do this, and I've talked about this numerous times, is if you've got a back pain patient who has urinary symptoms, you've got to treat their back pain and add in treatment of the sacral nerves to see if that resolves or gets better or improves. If it does, it's not occult tethered cord, and it never was. And it makes much more sense to do that because that's much, much less invasive, because that's an injection versus a surgery to go ahead and cut the filum terminale. So that's the big issue there, is to be really, really careful, because once you cut that filum terminale, that's a permanent change in the neurologic system and the biomechanics of the neurologic system that can never be undone. It's been advanced by DB. Could there be any connection between out of control upper GI inflammation and the vagus nerve issues? There can certainly be a connection between vagus nerve and GI. The only concern there is there are hundreds of other things that cause many of the GI types of problems that we're discussing. So it's one of those things where if you treat the CCI and the GI gets better, you know that the GI was probably related to vagal nerve irritation. But outside of that, it gets harder to tell. Bo, I have damage to the alar and accessory ligaments. Gotcha, Bo. Brian, how can orthobiologics be covered by third-party payer system when the demand is unlimited? Not sure the demand is unlimited, but we have, through Regenix, I think we're up to about 1,100 different corporations that cover this stuff, and they cover this stuff because orthobiologic interventional procedures, needle-based procedures, are less invasive and less expensive than orthopedic surgeries that they replace. So that's what's in it for them. As far as the demand being unlimited, it's really not unlimited. I would say right now, probably only 5% of the US population even knows about orthobiologic procedures. So while it may seem like there's a lot of demand on Facebook and in Facebook groups, that's a very tiny percentage of the total of people that are out there. Fetcha, I got 10 times worse from functional to unfunctional after high velocity manipulation successions. Chiropractor did not apply traction. I was sitting in one session and I did not relax. Yeah, so again, this is just one concept with regard to applying traction. I don't know what that chiropractor did specifically. Rishi, if a patient wanted to try less invasive procedures such as PRP or stem cell posterior injections for CCI, would there be an option to do this in the Cayman Island? I was just thinking the best least invasive treatment to do for considering PICL. No, in general, we don't offer upper cervical treatments in the Cayman Islands just because the infrastructure there isn't really in a place where it can support that very easily. So in general, it's not offered there. John, during the PICL procedure, do you inject BMC at the ends of the alar ligaments and transverse ligament or the whole body of the ligament? Both, depending on what it is we're trying to accomplish. Anya, you mentioned that conus medullaris can cause bladder issues. During last live, can I ask if on the terminality conus medullaris causes them? Well, I think what you're referring to there is a little different than what I was talking about. So the sacral nerves come from the conus medullaris, which is the end of the spinal cord, as do all lumbar nerves. In addition, the sacral nerves can get irritated at any of the spinal levels. Most common would be L5, S1, several levels below the conus medullaris. The sacral plexus can also get irritated as well, but it's mostly those sacral nerves. And the concept with filum terminale and occult tethered cord is that all of that's too tight and that's leading to the problems in the sacral nerves versus just the sacral nerves getting irritated, which is a much, much more common phenomenon than occult tethered cord. Fetching, felt pain in the neck for 1 minute. Could it be cause for damaged alar? Certainly possible. Strange, how to see is the AO same as PAOM? It's not specified in the checklist. Post-PICL procedure if the membrane or ligament is posterior category for sure per your checklist. AO is different than PAOM. PAOM isn't really a membrane, it's a ligament. It's an extension of the ligamentum flavum into the upper cervical spine. The AO ligament is separate. It's the posterior AO ligament that's being referred to there, and that's from the lateral transverse process of C1 up to the skull. I think this is, let's see. I don't know if I can pull that up because it's not letting me click on the link, but let me see if I can. Let's see if I can get it. Doesn't look like that's coming up. Regrettably, it won't let me click on that as an active link. So the best thing to do would just be to send that to me via email. I'll put the email address that goes to my desk down here. I'll be able to click on it and then get back to you separately because right now it's not letting me click on it. And when I try to search it under Google, it is not working. So I just put the email address that goes to my desk. So just send me the link directly. because it won't let me click on it right now. It's just showing me a picture of it. What do you think about spinal decompression therapy? I had PRP and C5 and 6 last November. I felt great first 2 months. Now I have inflammation at C6, 7. So I'm around PRP in November. Could I avoid spinal disc decompression? Should I avoid spinal disc decompression before PRP? Spinal disc decompression is just sort of super traction. And I think that super traction would be fine. There's really no reason to avoid it. Big thing to do if you're getting PRP is to make sure that you're actually getting PRP at that level, which would be a X-ray guide or fluoroscopy done injection into the facet joint with contrast confirmation, not ultrasound guided, not blind, and not necessarily just into the muscle, which is probably the most common thing you can get. So no problems with spinal decompression therapy, which is super traction. You do need to make sure that you're actually getting what you think you're getting. So if we were to take 10 clinics that advertise that they can inject C5-6, probably only one of those clinics would do it correctly. So that's a big problem to avoid. Fatchet, apart from alar damage and arterial dissection, is there any other serious damage with that kind of aggressive manipulation can cause that the medical community is aware of? I mean, the biggest one is arterial dissection. That one's been talked about quite a bit in the peer-reviewed medical literature. This one of alar damage is a relatively new concept. I've damaged my alar accessory indicated by overhang, lateral mass to the right of 4 and left of 4. Gotcha. John, do you think prolotherapy at any age in preteens can be beneficial for EDS patients? It can really help stop ligaments from getting too loose. Some kids heal fast. It would only take 2 or 3 treatments. Prolotherapy, in my experience, for most EDS patients works well. As far as younger versus older, I don't see a big difference other than maybe how quickly people heal. Unbelievable. Gotcha. I have degenerative disc disease that is fairly substantial in my lumbar as well as cervical. Are PRP injections beneficial? And they'd be given disc or facet joints. That's not a question that could be answered without looking at your imaging and doing a complete history. In general, platelet-based injections into the functional spinal unit, that would be the facet joints, the ligaments, around irritated nerves, which would be a transforaminal epidural, can be very helpful. You rarely need to go into the disc to get a full effect, and going to the disc adds substantial risk. Rishi, do you need PRP or stem cell booster shots going forward if you had improvement from posterior injections? For example, in 1 to 2 years, the results peak or the results long lasting on a permanent basis? Not quite sure what it is we're treating here, Rishi. So there would be, as you recall, 8 different types of CCI. So a lot of that would obviously depend on the type of CCI that we were treating as to whether or not posterior injections will help that kind of issue long term. So I would need to know more about the type of CCI we're treating. Anya, thanks so much for the answer. So if the issue is inconvenience, but rather problems with starting urination, the Druno treatments is the same. Yeah, I mean, that wouldn't be an issue. But again, Anya, all of this would have to go through a physical exam, history, review of imaging, etc., to see what makes the most sense for that patient. So I can't diagnose and give you concrete treatment recommendations just on a Facebook Live. That's obviously not fair to you. Caleb, any contradiction of consuming high amounts of salt in the diet and get ready for a regenerative procedure, EDS plus POTS, means of chronic blood volume expansion? I don't know of any at this point. You probably do need to realize that if you're getting treated by us, we're at higher altitude, a mile high. Denver is the mile high city, and it's dry up here. So that might be a double whammy, and you might need to get some fluids and stay better hydrated while you're here. Bo, I've damaged the alar and accessory ligaments indicated by overhang lateral mass of C1. Gotcha. Caleb, have you had any patients with very lax ligament anywhere on the body that had significant tightening healing with just one PRP treatment? Not very lax. I would say mild to moderately lax, yes. Unbelievable. I have had a malrotated C2 that has been sticking out to the right for quite some time. My PT and chiro both think the upper back strengthening exercises can stabilize and pull it back into place. Is that possible? Certainly could be possible, especially if you have some scoliosis causing it. Because remember, with all side bending of the spine, there's always a rotation. Mark, are the same forces at play when a hyper-rotated neck goes into whiplash motion and a rear end MVA? I don't think we know that one. In a rear end MVA, the biggest issue would be the S-shaped curve of the spine that happens as the seat back pushes the head or the thoracic spine forward and the head stays still. As to whether or not this mechanism would happen, that's a good question. I don't think anyone knows the answer to that. Nisa, if one does PRP in the shoulder, yet still has severe pain weeks later, can they do a steroid injection to help with the pain? When can they do this? Yeah, I mean, you would want to do a low-dose steroid injection, so a nanogram dose, which would be going to a Regenix site, not a milligram dose. So a milligram dose is about 1 million times physiologic. So to compare the difference between the two, a nanogram dose, if a nanogram dose is the height of a matchbook, a milligram dose is the height of the Empire State Building. So milligram dose steroid injections hurt tendons and kill off cells. Nanogram dose injections can help reduce inflammation without killing things. Anya, thank you. If it's not a cult to the cord but caused by sacral nerves, would there be pain in specific spine level or in legs, or can urinary problems and the only symptom of sacral nerve issues? Well, no, there's commonly pain in the legs because back pain can also cause irritation of other nerves that go into the legs. Or it could just be an isolated urinary problem if it's only sacral nerve irritation. So for example, I've seen patients with back pain who really only have the back pain plus the bladder issue. And I've seen patients with back pain who have back pain, urinary issues, and problems in their legs. Anya, can sacral nerves be treated with something else other than orthobiologics, like a nerve block or physio or something else? Unfortunately, orthobiologics aren't available here. A caudal epidural with high-dose corticosteroid, it's not something that we would do anymore because it's a high dose of steroid, as I was just talking about, but that's something else to consider to see if that moves the needle. Nature versus only AI, I'm not quite sure what that all means. This is the email that goes to my desk, as I told someone about before. I don't think I can get that link. Do you treat trigeminal neuralgia? Yes. John, what do you think PICL requires 2 to 4 treatments? Would one BMC treatment be enough to even heal a chronically torn ligament like the ACL? Yeah, certainly if it's the right ACL tear, we can do only one BMC injection. Now, why does PICL require more? Because I think the difference in most PICL patients is that this goes on so long without being diagnosed, meaning for years, that we start to see neurologic damage and injury that occurs. So if we're talking about acute upper cervical ligament injuries or acute CCI, most of those patients are one and done. That's all they ever need. But the difference here is if you leave a knee unstable for a couple of years, you may get some knee osteoarthritis, but you're not going to get chronic neurologic problems and neurologic damage as a result of that instability. Very different with CCI, where you will if you leave it untreated, or where some percentage of patients will. Let's put it that way. John, do male EDS patients have tighter ligaments compared to female EDS patients? Obviously, muscle thickness, strength is more in males, but curious about ligaments. Not that I've noticed. Robert, what treatment do you do for occipital neuralgia? Does it include steroids? Usually not. Robert, the biggest treatment for occipital neuralgia in a CCI patient is treating the CCI. Secondarily, you can also treat the occipital nerve. And to do that, that's usually done with a platelet lysate hydrodissection. It can also be done with PRP. Fatcha, apart from Alar, that other ligament that connects the C1 transverse process, is at risk for getting stretched? You mean posterior AO? Yeah, that certainly could get stretched as well. That one's impossible to image, however. Diana, how many TM injections are needed for increasing stability from severe TMJ? We usually do sort of 1 to 2, but a lot of that depends on what's going on with that particular patient's TMJ. AT, have CCI and ongoing pulsating at T6, potential for splenius capitis to be tight, leading to secondary stabilization, causing these symptoms. I doubt the pulsating at T6, I think that's what you meant to write, or thoracic 6 is due to the splenius capitis. Splenius capitis can become tight as a secondary, or really as a primary stabilizer with CCI. Doc P, enrolled live videos, you presented a one and done PICL patient. There's a physician who dealt with headaches, but more severe symptoms 3 months before PICL. They complained of a heavy head. I don't remember in any specific patient there. I think we had 3 of those in a row. We had 2 physicians and 1 physician's assistant, as I recall. I don't recall if any of them reported a heavy head, although I wouldn't be surprised if they did. Diana, how often can one get TMJ injected with PRP? Every 6 weeks. That's about right, every 6 weeks or so. Unbelievable regarding my degenerative disc disease. Approximately how many levels can be treated at one time with PRP? I'm trying to gauge how many treatments I would need to all the degraded levels. 3 to 4 is generally what we end up treating if we're talking about the whole functional spinal unit. However, if we're talking about just the ligaments, we can treat 5, 6, 7 at a time, that kind of thing. AT, an old video of PICL case study, a patient was presented with 3 treatments with big overhang improvement. Why did the overhang slightly decrease between each procedure? I think we were just showing an iterative, if I recall, I think we were just showing an iterative improvement after each procedure, meaning that the instability got less and less with each procedure, but I'm not quite sure specifically what the question would be here. Christine, are all these live streams archived somewhere? I missed the beginning of this one. Would like to watch. Thanks. Yeah, Christine, that's a good point. It's not something I knew the answer to until I looked as well. This was maybe 6, 8 months ago. So let's go to YouTube. That'd be the place to go. If you want to find old ones, now you can obviously try to find them on Facebook, but YouTube is probably the best place to find old ones. So if we go to YouTube, let me grab that screen for you. So if you go to YouTube and you type in and you find my channel, you can obviously just type in Chris Centeno and it'll come up. So I'm just going to go here to my channel because I'm logged in as me. And then you'll see here, home video shorts live. You click under live, and that's where all of my lives from the beginning of time, not really the beginning of time, but the last couple of years. I don't know how many are even here, but there is a lot of them. Looks like those go back to actually the last year of lives are there. So anyway, that's where the lives are stored and archived. So you can go back and see this one. That way you can also just go to Facebook if it's not too long from now. Go to either channel, the Regenix channel or Centeno-Schultz channel, and you can find it that way as well. Ulysses, are trigger point injections toxic to the muscles? Yeah, so that's the biggest concern about a quote trigger point injection. We know that lidocaine is toxic to certain cells. We know that corticosteroid is toxic to certain cells. And we have research that shows that just dry needling without anything works as well as injecting something. So obviously, if you want to inject something that's a net positive like PRP, then injecting a trigger point in a muscle is fine. But if, on the other hand, we're in this situation where we would otherwise inject corticosteroid or lidocaine or marcaine, we know all those things can hurt the muscle. So better just to dry needle it rather than get those things injected. Dry needle means just using the needle without injecting anything. Brett, for CCI, what other images tests do you send off prior to treatment? We need a routine cervical MRI. It's great if you have a digital motion X-ray or functional MRI with flexion extension. We can start with as little as a routine cervical MRI, however. Stefan, could Mondural bridge be injected with stem cells PRP? It can be. Anya, thank you. Do you think sacral nerve irritation can get better from following terminality surgery? Maybe the surgery also works sacral nerve issues, is more dangerous than injections. Yeah, Anya, that's just not a good idea, right? We keep patients safe by only doing the least invasive thing that's the most likely to help. Cutting the filum terminale is big surgery. It's neurosurgery. And doing an injection is going to be far, far safer with a much, much lower complication rate. And so to put it in something that you'd understand, it's like the difference between open heart surgery, which we all would know is pretty darn invasive, right? There are people that die in open heart surgery because some of those people are pretty sick when they go in. And we're cracking open the chest, right? We're opening up the sternum, we're breaking ribs to get in there, etc. Versus a catheterization procedure where they're floating a catheter to open up an artery. Obviously, I hope that you'd all know at face value that the open heart surgery is dramatically more invasive than the catheterization procedure. Same thing here. Thanks, Dr. Gaddis. Hey, Dr. Gaddis is one of our fellows this year. Great, great guy. Highly recommend Dr. Gaddis. Big thumbs up there. Yes, you can see. That's right. Actually, this is pretty funny. You can see my hair grow back, and you can also maybe see it get browner as time goes on. Bo, I have damaged the alar and accessory ligaments overhang of C1. Don't need high quality injection care. We've seen Dr. Wood in Oregon soon. Any suggestions? Yeah, there's no way that anyone's going to treat your alar or accessory ligaments or overhang without a PICL procedure. I don't know who Dr. Wood is in Oregon, so let's see who that is. Let's see. Like, obviously, that's a really, really common name. Oh, the naturopath. No, I wouldn't recommend seeing a naturopath to inject your upper cervical spine. I think that's just super dangerous in my opinion. And he's not going to come anywhere near or close to your alar ligaments. In addition, a naturopath is not an actual board certified physician. In general, naturopaths would have only a tiny fraction of the training, the medical training, of a board certified, let's say, interventional spine physician. So no, I wouldn't recommend Dr. Wood to do anything like that. Unbelievable regarding my malrotated C2. If it's due to ligament damage, is there typically a procedure or certain ligament that needs addressed? What determines if it's C1, 2, or 2, 3? Well, the first thing is to get a diagnosis as to which ligaments are damaged and which type of CCI you have. So that's something that would have to be done in a telemedicine appointment. So for example, the ligaments injected, if it's a CCI type 1C, are very different than if it's a CCI 3A versus a CCI 2B. So the first thing is getting an actual diagnosis. Then that diagnosis leads to treatment. Christine, thanks so much for showing where to find the archived lives. Sure, Christine. Dispatch 151, if there's major compression of 3 on 4, is there any particular scan test that can prove that they're still individual vertebra versus congenitally fused? Yeah, I mean, an MRI will show if there's a congenital fusion, for example. If there's some concern about things not moving correctly, then a digital motion X-ray or even just cervical flexion extension radiographs done with full range of motion would be good places to start to see if those areas have normal motion. Manuela Trican, what would be your advice if after 3 PICLs I still experience a lot of pain at the base of the skull? Does it mean it's not working for me or I need more treatment? I don't have any other symptoms left. Only the pain and the neck muscles are weaker and started to hurt. Manuela, I don't think I've been seeing you, so it's hard for me to comment, and it certainly wouldn't be right for me to comment here even if you were a patient. But I can tell you in general that some patients may need some additional investigation as to where, if all the other symptoms have gone away, but that pain up top, as to where that pain is coming from. So that would be diagnostic blocks in the high upper cervical spine, looking for the specific structure that's causing that remaining symptom. John, in reply to Bo, it seems you are new to this whole CCI thing. Don't waste your money on these low-quality clinics. Overhang is Alar ligament injury. Yeah, I would tend to agree with you, John. As you know, I've said that many, many times. We're talking about a level 5 injection that's required to treat that issue, and starting with a level 2 injection, someone that's trying to use some ultrasound to inject the big ligaments in the neck is generally not going to help in my clinical experience. Plus, you've got the whole issue that I discussed before, and that is, if you're going to have someone do low-level injections, at least get what I would call a real doctor, meaning somebody who has gone to 4 years of college, 4 years of actual medical school at a real university, someone that's done an internship, someone that's done a subspecialty training, whether that be a residency plus fellowship. So by the time we're done here, we're talking a minimum of 12 years, all the way up to 16 years of education versus a naturopath who probably has the equivalent in that world of 5 or 6 years of education or less. So lots of different things to unpack there, but I think John's right. For type 2B in our experience, you generally need treatment of the alar ligaments, and that's not going to happen at those lower level clinics. John, do you think that there will be something superior to BMC for healing ligament sends in the future? Will increase effectiveness in these procedures just be from better placement, et cetera, going forward? Yeah, John, I think we've seen both, right? We've evolved the procedure over time substantially. So for instance, May of last year, we started to add in dual CRM fluoroscopy. That was a big change because it allowed us to dramatically increase the accuracy. And there may be a few more things that we do over the next year or two, but we're about 90% of the way there towards improvement of the procedure. Maybe we've got 5 or 10% more we can eke out of it. And then you get into improvements of what can be injected. Here in the United States, regrettably, all we can do is same-day stem cell stuff, and that would be things like bone marrow concentrate. But we certainly eventually will get FDA-approved treatments that are more advanced. We'll start to see culture-expanded cells. So, for example, I licensed one of my patents through Regenix to a company that's doing a phase 2 FDA trial in discs right now. If we could use that stuff in these ligaments here in the United States, that would probably be another big leap forward. But that's probably 3 to 5 years away from getting approved. We will eventually see in the 10-year horizon, we'll start to see genetically modified cells that are sort of super healers. So there's a lot coming down the pike here in the next 5 to 10 years. AT, the video was PICL procedure case study in severe CCJ. The patient improved drastically each time, but slightly increased prior to the next procedure, so I was wondering why it was. Yeah, I think what we're seeing there, if I recall, I think that was a physical therapist who had been in a pretty severe accident. If I recall, he actually sued a major car manufacturer and won because he's a big guy. He's probably 6'3", 220, 230 pounds. He's rear-ended, and the seat back collapsed when he was rear-ended, and he ended up in the back seat with his head pointed towards the trunk. So he had a very, very severe injury. It had gone on for many years before we got him. And yes, he was getting incremental improvement with each injection. Brett, I've been dealing with many CCI symptoms for months now, visual disturbances being one of the major ones. What do you see as the major cause of visual issues in relation to CCI? Yeah, Brett, the biggest thing that we tend to see is usually coordination of the eyes, which is through upper cervical input in the neck. So what I mean by upper cervical input in the neck is that the upper cervical proprioceptors help to coordinate eye motion. And then we see discoordination of eye motion. Now, it's also possible to get sympathetic type issues. And I've done a Facebook Live on that in the past. And so that would be irritation of the sympathetic chain. What we tend to see there are more pupillary constriction abnormalities, and that leads to problems in accommodation, meaning problems in how the lens works. So those are the two biggest things we tend to see. Gotcha. Anya, thank you. Yes, I understand it's more invasive. Do you think minimally invasive terminology can be safe, not cutting the dura? Yeah, it's still, even though it's called minimally invasive, that's a sales tactic. It's not minimally invasive, meaning it's a surgery. It's still an incredibly invasive thing to do, cutting the filum terminale. You're making permanent changes in the biomechanics of the central nervous system that can never be undone. So obviously you wouldn't want to do that before you had tried other things that are less invasive. So nothing minimally invasive about cutting the filum terminale. That's a big surgery. And listen, God, I've seen so many filum terminale disasters at this point. It's hard to even keep count, meaning I've seen chronic dural leaks due to this surgery that never got fixed. And those patients are just screwed for life. I've seen multiple infections happen in these patients, and that leading to other issues. I've seen failed surgeries that then go into second and third procedures. Now, listen, I'm sure there are lots of people that are quite happy with the results, and I'm obviously going to see the folks who aren't. But at the same time, these types of issues that you see with surgeries like this are much, much bigger than the types of issues that you generally see through injection-based procedures. And that's just the nature of the difference in invasiveness. Fatcha, muscle tightness of the neck is different from muscle atrophy and muscle spasm, or is it like a process tightness, spasms, then atrophy? Well, spasm is just tightness in the muscle. Atrophy means the muscle or a part of the muscle dies off. And then Rishi is a high-functioning patient with CCI likely to do better with treatment than a lower-functioning patient, even if the higher-functioning patient is pushing through pain every day, such as headaches. Yes, in general, Rishi, higher-functioning patients tend to be those that get complete remission. Lower-functioning patients tend to be those who have a much, much steeper climb to get back to anything approaching normal. Okay, guys, it looks like we are at an hour and 4 minutes or so since we started. And it looks like the questions are starting to peter out a little bit. So certainly throw at me your last minute questions here. In the meantime, today we were talking about some biomechanical things that happen with C1, C2 rotation to protect the alar ligament, and how that could explain why we see some patients who get high upper cervical alar ligament injuries when they have a rotational manipulation of the head on the neck, and especially when there's traction pulled as well. Sure, Anya, happy to help. Okay, so I think we're done for today. I want to thank everyone for taking the time. There are no bad questions here. They're just questions. We all learn through asking questions. And I want to make sure that we always have a safe space where we can ask lots of different questions so I can try to get the word out there and educate patients as best I can. In the meantime, I will be here this Friday. We'll have another topic. I know someone brought up the topic of upper cervical suboccipital muscles. That sounds like a great topic. So I'll maybe try to get to that, or we'll do something else. But you all have a great week. And thank you so much for your time today and all your questions.